To address the clinical issue of managing exacerbations in the home environment, our key clinical activities are to incorporate four components of care and develop a written asthma action plan. Our action steps related to these activities are to include assessment and monitoring, patient education, environmental control, and medications. Instruct your patients how to recognize early signs, symptoms, peak expiratory flow measures that indicate worsening asthma, adjust medications, and remove or withdraw from environmental factors contributing to the exacerbation. Monitor response and seek medical care if there is serious deterioration or lack of response to treatment. To address the clinical issue of managing exacerbations in the urgent or emergency care setting, our key clinical activities are to assess severity, trial to relieve hypoxemia and airflow obstruction, reduce airway inflammation, monitor response, and discharge with medication and patient education. Our action steps related to these activities are to assess initial severity by lung function measures if you're greater than age 5 and symptoms and functional assessment. Give supplemental oxygen, repetitive or continuous short-acting beta agonists, oral systemic corticosteroids, monitoring the response with serial assessment of lung function measures, pulse oximetry, and symptoms. Consider adjunctive treatments like magnesium sulfate or Heliox in severe exacerbations unresponsive to initial treatment. Providing at discharge medications like your short-acting beta agonists, oral systemic corticosteroids. Consider initiating ICS, referral to follow-up care, an emergency department asthma discharge plan, review of inhaler technique, and whenever possible, environmental control measures. Differential diagnostic possibilities for asthma in infants and children are upper airway diseases like allergic rhinitis and sinusitis, obstructions involving large airways like foreign body and trachea or bronchus, vocal cord dysfunction, vascular rings or laryngeal webs, laryngeotracheomalacia, tracheal stenosis or bronchostenosis, enlarged lymph nodes or tumor, obstructions involving small airways like viral bronchiolitis or obliterative bronchiolitis, cystic fibrosis, bronchopulmonary dysplasia, and heart disease. There are also other causes like recurrent cough not due to asthma, aspiration from swallowing mechanism dysfunction, or gastroesophageal reflux. Differential diagnostic possibilities for asthma in adults could be COPD, congestive heart failure, pulmonary embolism, mechanical obstruction of the airways, pulmonary infiltration with eosinophilia, cough secondary to drugs, or vocal cord dysfunction. Monitoring of peak expiratory flow or bronchoprovocation may be helpful. Diagnosis is confirmed by a positive response to asthma medications. VCD, or vocal cord dysfunction, can mimic asthma, but it is a distinct disorder. VCD may coexist with asthma. Asthma medications typically do little, if anything, to relieve the VCD symptoms. Variable flattening of the inspiratory flow loop on spirometry is strongly suggested of VCD. Diagnosis of VCD is from indirect or direct vocal cord visualization during an episode, during which the abnormal adduction can be documented. VCD should be considered difficult to treat atypical asthma patients and in elite athletes who have exercise-related breathlessness unresponsive to asthma medication. Gastroesophageal reflux disease, or GERD, obstructive sleep apnea, and allergic bronchopulmonary aspergillosis may coexist with asthma and complicate diagnosis. Children ages 0 to 4 years. For diagnosing infants and young children, it's challenging and is complicated by difficulty in obtaining objective measurements of lung function in this age group. Caution is needed to avoid giving young children inappropriate prolonged asthma therapy. However, it is important to avoid underdiagnosing asthma and thereby missing the opportunity to treat a child by using such labels as wheezy bronchitis, recurrent pneumonia, or reactive airway disease. The chronic airway inflammatory response and structural changes that are characteristic of asthma can develop in the preschool years, and appropriate asthma treatment will reduce morbidity. You should consider referral to an asthma specialist if signs and symptoms are atypical, if there are problems with the differential diagnosis, or if additional testing is indicated.